Welcome to Radio Corona. I am Gideon Litchfield. I'm the editor-in-chief of MIT Technology Review, and we're very, very happy to have you here with us on the show. Joining us today are Neil Patel, who is MIT Technology Review's space reporter most of the time, but for the duration of the crisis, he is our COVID testing reporter, and he's been writing all about the ways in which testing is ramping up, the technology of testing, how to get tests more efficient, how to get them faster, and why there is such a backlog of tests, particularly in the United States. And joining us also is Eric Huang, who is the Assistant Dean for Bioinformatics at Duke University. Thank you very much for coming on the show, Eric.
Absolutely, happy to do it.
So, Neil, I want to start by talking about the story that you published a few days ago on Tech Review, and it's about how the US testing regime is in chaos, or in particular data from testing is all over the place and very hard to organize. Tell us a little bit about why that is.
Sure. So we're obviously hearing a lot of stories right now about how we need to rapidly increase the amount of testing we're doing. You know, some estimates are calling for at least 1 million. Some would prefer close to 5 million a day. But it started to occur to me that there's a problem. If we increase testing, how are we actually going to start collecting and reporting out all of these results efficiently? Public health in the US is run primarily by the states and in some instances by localities, by smaller municipalities. So they're the ones in charge of collecting the testing results and reporting them up, and eventually everything gets up to the CDC. But it's up to the states to kind of decide how they want to approach this. And what I started finding out was that between different states, between different municipalities within those states too, there's different protocols for how to run this. Some people are doing this, with the current state-of-the-art kind of infrastructure and software that's required to report these results. Some are doing them just on Excel sheets. Some are faxing those results off to the state health department. It's just a mess, and it's a huge concern when we think about how are we going to ramp up testing. We're just going to reach another bottleneck where we don't understand how are we supposed to get those results to the state departments effectively, have them make sense of it and organize it in a way that anyone in the country, especially researchers and epidemiologists and other public health officials who are trying to use that data to help policymakers make informed decisions, how are they going to actually present that data in a way that's uniform, that makes sense to everyone, that no matter where you are in the country, you can look at this and say, okay, I understand what's going on in this region and what we can do, whether it's prudent now to lift the lockdowns, increase social distancing measures, et cetera.
Right. As you mentioned, these results get sent up eventually to the Centers for Disease Control. Now, at the moment, the most reliable data that there are on how many tests are being done in the United States isn't coming from the CDC. It's coming from the COVID tracking project, which is this thing launched by some journalists at The Atlantic that's now been running a few weeks. They show that the US has reached is doing roughly 300,000 tests a day. If you went to the CDC's own data, you would see a far lower figure than that. So, I mean, maybe Eric, you can weigh in on this. How is it possible that the country's central health authority doesn't have data? Why is the US this way?
So many people have pointed out amidst this crisis that it's really highlighting a lot of the cracks in the US healthcare system. And transfer of information around our health system is actually one of the big problems that we have. In fact, at the beginning of March, the Office of the National Coordinator, which is in the Department of Health and Human Services, had actually dropped the final rule, which is basically the enactment of the federal legislation, the 21st Century Cures Act, which was passed in November of 2016. And one of the goals of that final rule was to address the questions of interoperability and data blocking. These are exactly the same kinds of problems that we're dealing with that Neil described in terms of our ability to transfer information around that helps us manage health issues. So the problem is it's probably historically sort of part of American culture is that we're very individualistic and entrepreneurial. and we'd like people to have the autonomy to build systems and do things on their own. What that's left us in healthcare is that we have many health systems, some bigger, some smaller, but we don't really have a national standard for exchanging data, except now as enacted in the 21st Century Cures Act. Unfortunately, that final ruling just dropped in March, so we actually have not caught up to what the aspirations of that legislation so that we can exchange information about testing, because testing is something that we want to do not only to gather information about the individual patient that's in front of us, but we want to use all the aggregate information about testing to help us manage public health issues. And I think it's simply sort of tragic to think that, and I love the fact that the Atlantic has done that effort to aggregate those data, but those are kinds of things that we should be able to do at a national level. And unfortunately, with all the playbooks that have been out there in terms of managing pandemics, those have sort of been at odds with the fact that our healthcare sort of culture and business practices have never really been aligned with useful exchange of information across borders, counties, states, across the country.
So how does the US handle other public health problems like HIV/AIDS or even flu, where you need national level statistics and you need some kind of national response? And this is not the first national health problem the US has encountered.
Right. The CDC has surveillance networks for other known infectious diseases, and certainly for influenza, there exists one. But when it comes down to it, still the data are good to have. But when you start digging into it, it's actually relatively rudimentary. And when you consider how sophisticated we are now as a nation with our ability to use machine learning, Google Assistant can tell me what my daily commute might be, except nowadays. It's sort of the disjunction between how we really could use data and the way we actually do in healthcare is quite wide. And I do think that one of the things that we need to navel gaze about amidst this crisis, and certainly many people are thinking about that, is how do we do better next time around? And certainly how do we do better within the, who knows how many years, this process is going to be, before vaccines become viable. We should start now.
Yeah. I want to ask you about that in a second. Neil, first I want to come back to you. One of the things that you wrote in your story is as you said, new testing platforms will make the data collection problem worse, because as we develop new kinds of tests for COVID, and whether it's antibody testing or other sorts of testing, it could actually get harder. Can you talk a bit about that?
Definitely, yeah. I think the first thing everyone should sort of understand is, when it comes to COVID-19 testing, there's sort of two kind of major approaches. One is to diagnose to find new cases, and the other is what we're starting to hear much more of these days, testing for immunity through antibody testing. And that the goal behind that is to find out who has already been infected, may not have been already diagnosed through the standard diagnostics, but who's already been infected and potentially now immune. Now, putting aside the questions about what we don't know about immunity yet, let's just assume the testing works well. There's the uncertainties that have been raised on both the diagnostics and the immunity platforms are no longer concerned, hypothetically. We still run into a problem that there are so many different testing platforms. So we're starting to see that when it comes to diagnosing for COVID-19 for new cases, people are trying to roll out rapid testing through, the Abbott rapid test, for instance. There's antigen testing coming up that's purportedly designed to be a much faster way to find new cases. All of these things are not sort of they don't necessarily have to be run by a state department testing protocol. That's good in the sense that you can get your results super fast and know that you might have it, and then you can finally figure out what to do from there. Your physician can help you figure out what to do from there. But if those test results aren't being reported anywhere, then we're just left with a big hole that of where the new cases are going. Now let's look at antibody testing. All these new platforms that are supposed to find out who's immune. The main draw from almost all of those platforms is the ability to take those tests at home or at your point of care facility. Again, there's no protocol for how to get those results, directed anywhere above you to a state health department to help them figure out who's actually immune, what populations are maybe have developed herd immunity, which populations are more vulnerable. Epidemiologists can do nothing with that data. There's just nothing in line yet to figure out how to collect all of this into one central repository that can organize it and then make it available to everyone.
Right. Well, people are talking about companies, for instance, testing their employees to allow them to come back to their offices. So, I mean, have you come across anyone talking about how that would work and how that data would get distributed?
I've talked with a few. I haven't talked with any companies directly. Every company is being sort of cagey about any kind of purported plans like that. But I've talked with a few people who have heard, from the rumor mill about different companies thinking about that stuff. None of them have raised any kind of idea that these companies have a clue about what they would do with those results besides just using them internally and having their employees know if they're infected or not, if they're allowed to come into work or not. That's one example of a huge concern. You have an organization that is doing the testing, and if they're doing it reputably and usefully, that data should go somewhere so that the rest of the community can, understands the numbers and then can use that in some useful capacity.
Right. Eric, are there any mechanisms or any ideas about how that kind of testing data, for instance, from companies, can get channeled to the public authorities?
Right. So it's interesting to think about, because a health system, if you do testing, and I'm sure there may be some different in state statutes and things like that, you have to report them to public health authorities. Now, when a company does that, I'm actually not sure what statute says from that standpoint. And certainly Neil alluded to the fact that at some point people may be able to self-test, and then again, there's no standardized way to funnel all those information up to a place that should aggregate those information so that we can utilize them for public health purposes. There are efforts that are beginning right now. So I'm aware of Eric Paraxis, who's a co-author with me on an editorial we wrote in Stat News. I know he's been talking with some test manufacturers about creating a standardized sort of application sidecar to the diagnostic device that will report up standardized information about that. But that's only happening right now. And of course, that's one particular manufacturer. We should probably have a standard for all the device manufacturers. And of course, then we still haven't addressed the issue is still there's a large degree of, especially like academic health systems who have very capable labs who have done their own homegrown tests. Those certainly have to report up to public health authorities, but there, as Neil alludes to, there's just such a cacophony and sort of a Tower of Babel that we've built for ourselves when it comes to reporting test data.
Right. So what would it take to impose some order on this cacophony? I mean, we've got a system in the US, and I think this is particularly fascinating to people in other countries, but the system in the US is a product both of the decentralization of political power, the federalization to the states, and also a privatized healthcare system in which the healthcare system itself is decentralized. But what would it take to impose a single data standard, for instance, and who could do that job? Right. So that final ruling, for instance, that I alluded to at the beginning of March by the Office of the National Coordinator, that's beginning. That didn't define the data standard for COVID-19 specifically, but it really did embrace a data standard that's called the Fast Healthcare Interoperability Resources Standard, which is an open source standard that's basically sort of stewarded by HL7, which is a very well-known health data standards organization. That FHIR can definitely be utilized as a what I call a data interoperability standard for COVID-19 type data. And as Neil quoted me in the article, there have actually been some groups that put out a proposed sort of implementation of using FHIR for COVID-19 reporting. We should embrace that, right? Because that data standard was actually designed very specifically for being web friendly, and the way most data is exchanged at scale in this world nowadays is via web API type standards. Google would grind to a shut if they couldn't do that. So
I think this is a really viable way to do this. We only just started priming the pump in March. It's unfortunate that we had this crisis just drop on us before we could actually get this implemented at scale. And I'll be honest with you, there'll be resistance to that data standard because electronic health record vendors like to keep things a little bit proprietary because they want to create data moats and data silos and business advantages because of that. So that is, orthogonal to our desire to actually try to do something at a national scale to manage these public health type issues.
Is this something where, in principle, the CDC or the White House could, in theory, mandate it? Say, you guys all have to follow this.
I would honestly invite that. I think if at the federal level, and it may not even have to be a mandate, but really just like, guys, let's get together on this. Can you imagine, let's say, the armed forces where they didn't have a standard like caliber for, bullets or something like that, and everyone had to come up with their own version? I mean, we do standardize on things. And actually, the military is a good example of a organization that's spread across the world that has a lot of imperative behind it when we have defense issues. We should be able to do the same thing from a public health standpoint as well. Is like, yeah, we should have a standard caliber for exchanging test data.
Right. So someone on the audience is asking me a question about something I don't know. The laboratory response network. How does it factor into the discussion? Do you know what about the laboratory response network?
I'm not personally familiar with the laboratory response network. I love the sound of it, and certainly for a laboratory response network to work, that means there still needs to be sort of a standardized data exchange layer. And I know just for a fact in healthcare we don't have that right now. So I would say that efforts like that, any response network, really depends on an appropriate data exchange methodology.
All right, just to remind you, if you're watching, this is Radio Corona with Neil Patel from MIT Technology Review and Eric Huang from Duke University, and we're talking about data standards for the US. So let's talk a little bit about other countries which seem to have managed to sort this out. What do you think, to the extent that you know how other countries are handling this, Eric? What do you think is a good model that the US could be following?
Right. So I think one good example is Taiwan. A good friend of mine, Jason Wong at Stanford, actually wrote a pretty well-read JAMA paper, the Journal of the American Medical Association's journal, about Taiwan's response. And I haven't looked at the latest numbers. My parents live there, and my parents are a lot less stressed out than I am. And what Taiwan was able to do was, they have a national health insurance system. So they had a national health insurance database. They could join the national health insurance database with their immigration database. And that joined set of data became especially powerful for them to identify issues and to make sure people stayed quarantined. So they were able to, and of course, Taiwan and Singapore and Hong Kong, those countries saw the writing on the wall when SARS happened, and that probably motivated them to be a little bit more structured in their response. But I think many people have argued that the public health handbook on responding to pandemics is well known. Under George W. Bush, we have a pandemic response playbook. WHO has a pandemic response playbook. What those countries like Taiwan have been able to do is just, they've executed much better. They followed the playbook. For us in the United States, it almost feels like we ignored the playbook, and actually probably continue to ignore the playbook to a large degree, even though that was written under a Republican administration.
Yeah. Go on, Neil.
I just wanted to kind of ask Eric, one of the things that a lot of the researchers that I was talking to sort of raised was that having a decentralized kind of public health system, not necessarily a bad thing, given that the US is, how big it is, so many different disparate populations, and that the state and local health departments might be better catered to kind of understanding how to, in a case like this, understanding how to better test and then report those results. I'm wondering if I can maybe just get a little bit more thoughts from you as to kind of, the fact that we haven't moved to something more centralized right now means that there's a pushback because, there must be theoretically some advantage to that decentralization. And I'm wondering if there's, if you can talk a little bit about whether there is something like that when it comes to dealing with the pandemic.
I'm of two minds about that. So I'm not sure whether it necessarily confers. I mean, I guess they're saying that some, the public health departments in different places can sort of be more culturally attuned or socially attuned to to their populations and respond to those in appropriate fashions. I believe in the American way. I believe in American democracy and things like that, and I believe in rugged individualism. But I do think that can still coexist with some sort of standards. Like we have standards for octane and gasoline. We actually follow lots of different types of standards. We use pounds per square inch to measure pressure. So I think in this case, we can allow public health agencies in their localities to operate in specific ways, but we just say, hey, let's also have a lingua franca for exchanging information about these kinds of things. And the thing is, it only benefits everyone because there's a whole ecosystem that arises when there's a standard. The reason why big tech is able to operate the way they operate is their standards like HTTP, and they are able to use that standard as a way to actually innovate further because they know that that's a predictable thing. I think we need to try to do the same thing in healthcare.
What do you think is what's the nightmare scenario here if we don't get things right? I mean, in other words, if we ramp up testing, if we're doing 1 million tests a day, but if that data is not being treated in a standard way, then what happens?
So, one thing we always learn in medical school is don't order a diagnostic test unless you have something you're going to do with the result. So all this testing is honestly for naught unless we have an intervention for that testing. And certainly there are interventions we can do for individual patients if they're showing up in the emergency room. But from a public health standpoint, what is that intervention? And there's no way getting around the fact that we need these data so that we can enable contact tracing to happen effectively. Now, obviously, we also have the problem is that there's not enough contact tracing capability across the country. You guys are in Massachusetts, and obviously your governor has prioritized that for the state of Massachusetts. That's not been uniformly embraced by governors across the country. There's no getting around the need for boots on the ground contact tracing. I think, those interesting technologies like Bluetooth contact tracing and things like that are going to be useful adjuncts, and of course there are privacy concerns about those that people rightly should pay attention to. But in the end, boots on the ground contact tracing, making sure when someone actually has a positive test and they're not needing to be hospitalized, that they are quarantined. I mean, I don't have a good systematic sense that we are systematically quarantining people who are test positive, but without having significant symptoms. I don't get much sense of that at a national scale. So just like we learned in medical school, you've got to have some intervention that you're going to perform if you're going to order a test. Right.
Let's come back to the interoperability question. So we talked about this a little earlier. You mentioned that there is this new standard for interoperability, and that some healthcare systems are starting to use it. What do you think has to happen for it to get widely adopted?
A lot of people ask that question and scratch their head. So obviously 21st Century Cures was a way to start that process by actually making it federal legislation. That's one way to prime the pump. I actually think at some point we have to consider whether reimbursement becomes part of that equation, right? So the push-pull is, well, you need to give us the data in this standardized format before we'll actually reimburse you for the services that you provide. And I think ONC is trying to create that push-pull process. Frankly, in this country and with the U.S. Health systems, the bottom line is often the biggest motivator. So that certainly can be one way. What other people try to do from the other side of the equation is try to show, well, if you have data in these that follow these standards, then we can start much more easily implementing things like using artificial intelligence in let's say clinical diagnostic support. So those high value type things that you can do with great technology. The reason why Google is so good at machine learning is because they've standardized the data for themselves. So I think it probably has to come from both the reimbursement end and also what good services can you provide your patients. And they don't need to be machine learning. They can just be great apps, because I think most of you in your encounters with the health system sometimes feel, well, it still feels pretty backwards. I can't make an appointment very easily. Maybe some health systems, but in many health systems, you can't make an appointment that easily on your iPhone or something like that. So I think there probably has to be multiple ways to incentivize health systems to adopt these kinds of standards.
Right. I would add to that too. I remember my conversation with Eric Praxlis, Eric's colleague. He was emphasizing the fact that when you have just way too many solutions to pick from, you're not going to get anything that's adopted wholesale. If you have something that works, then there needs to be a consensus to just run with it. And one of the problems we're running into right now, not just when it comes to interoperability software like this, but also with testing, is there's just way too many solutions to pick from. And at some point, we're going to need to find a way to just come together and say, I think this is the one that works the best, or this is the one that's most suitable for us, and just adopt it.
Right. I mean, it's a very stereotypically American response, right? Let a thousand flowers bloom, but God forbid that anybody should choose which of the flowers to water.
Right.
Lots of people on our chat are apparently curious about blockchain and whether it can be for any of this. But you were expecting this question. How about it?
I definitely have an opinion. So, I mean, blockchain is a fascinating technology. And, obviously blockchain was engineered originally for cryptocurrency and trustless exchange of, value. Certainly the cryptographic components of blockchain seem appealing because, it was designed to allow people to exchange currency in a completely anonymized way. Now, whether that actually works for healthcare and works for COVID-19 testing data, I actually think what all the cryptographic guarantees of blockchain create is a lot of burden, right? There's computational burden because there's a lot of like proof of work type work where you have to burn up a lot of cycles just to create a block. You can have blockchain, you can have proof of work-less type blockchains, but in the end, when you think about it, blockchain is a distributed data store. It's a distributed, database, and you can either trust people or you can not trust people. I think amongst people who are taking care of other people, we can establish trust, right? Blockchain exists for trustless environments. We can establish a framework of trust for public health agencies to have access to those data. So I don't see really the necessity of adding all that heavyweight cryptography on top of just basically a distributed database in order for us to exchange data with one another. I think, there are plenty of other ways for us to do that in appropriately secure ways that will satisfy HIPAA regulations and standard security type standards like SOC 2 type 2 or whatever. So I feel that blockchain will potentially have uses where that privacy and cryptography is really essential, maybe in the mental health space, and let's say in the opiate type situation where you need to have knowledge about that. But for this particular application, I think we should just say, look, we need to have a shared database. That's it.
Right. Yeah, because blockchain doesn't solve the problem of adoption. You have to get everybody using the same system. Otherwise, it doesn't matter whether it's blockchain or something else. We're pretty much running up against the time, but are there any other suggestions, I guess, Eric, that you would have for, whether it's people in healthcare systems or people in policy about how to try to bring all of this together and create a standardized testing framework?
I think some of the way out of this Tower of Babel, and I've actually blogged about it in my Duke blog and have published about this, is that this sounds abstruse, but application programming interfaces are really the way to help drive us in healthcare towards better data exchange.
So just in case they don't know.
Yeah, so application programming interfaces, or APIs, are sort of the way systems talk to each other in this modern age. So for instance, on your mobile device, whether it's Android or an iPhone, the reason why the apps are so compelling on your mobile devices is that they utilize APIs. So let's take a rideshare app. A rideshare app, when you think about it, just leverages programming interfaces for geospatial data, authentication, and credit card authorization. And just joining 3 data exchanges between those kinds of things all of a sudden give you a rideshare app, which, for better or worse, has been a revolutionary change, innovation, if you want to call it that, in the application space. For us in healthcare, we need to get used to the fact that, well, not used to, we need to warm up to the fact that exchanging data the way our iPhone exchanges data with Uber or Lyft actually helps us come up with innovative new models and applications for using healthcare data. The problem with healthcare data traditionally is we just shove it into a data warehouse and it just goes and sits there and rots. We do use it for reporting and stuff like that, but an application world where you use application programming interfaces all of a sudden unlocks those data in ways that make it useful. And then the more you use the data, the better data standards get because people are using the data. So I think it's one of those things where we need to prime the pump, demonstrate situations, as Eric Caraxes alluded to, where you can really show great value in this particular application in the healthcare space, and then basically use that as a way to trigger innovation and broader adoption of standards like FHIR, which are very API friendly.
And is that a regulatory problem as well? Is there a problem with sharing data through APIs, or is that already basically taken care of?
A lot of people bring up the sort of the boogeyman of privacy and security and things like that. Well, in some ways, actually, APIs actually make securing data actually better and easier because you can basically, the way current APIs are designed is you can put restrictions on who can use a particular API, and you can give them expiring keys to an API. And so you can manage that. Whereas in the old days, if you gave someone access to the database, they could run amok in the database. With an API, you can just give them that specific stream of data that they need for a particular purpose, put a lot of authorizations around and authentication around that particular API, so you can control your channels of data in a much more granular way. I actually think that actually will improve the privacy situation and the security situation when it comes to applications in healthcare.
All right. Well, I'm going to wrap it up there. I want to thank Eric Wang and Neil Patel. Thank you very much for joining us. And if you were watching, I hope you've enjoyed this show. Just a reminder that we are having in June our virtual conference, MTech Next, which is about the future of business and technology. We'll be covering all sorts of things like blockchain, AI, 5G, Internet of Things, and also how to adapt your business in the midst of a crisis like COVID. So there'll be lots of interesting sessions there. It's in partnership with Harvard Business Review, and we'll cover a really wide range of really relevant topics. So thank you for watching, and come and join us on the next episode of Radio Corona. Thanks very much.
Thank you.